Good morning. Okay, welcome to Chapter 37 of Adult Med-Surg Nursing Care of Patients with Disorders of the Urinary System. This lecture, because this is a kind of long chapter, is going to be divided up into two parts for Chapter 37. So this is part one. What are we going to talk about? We're going to explain what are the causes, symptoms, labs, abnormalities, treatments of urinary tract infection, what causes kidney stones, and how they're diagnosed and what we have to do for our patients. We're not going to talk about kidney cancer. That will, again, be reserved for the chapter on cancer, so a little bit later on in the term. We are going to talk about the ileal conduits. We're going to talk about diabetic nephropathy, nephrosclerosis, hydronephrosis, glomerular nephritis. That's a mouthful. And we're definitely going to learn about chronic kidney disease, the difference between chronic kidney disease, acute kidney injury, and patients that do have CKD, chronic kidney disease, and hemodialysis and peritoneal dialysis, and what your job is as the nurse to take care of patients with those disorders, okay? All right, so we are going to start with urinary tract infections. So most urinary tract infections are caused because bacteria is able to get up into the urethra and then travel up the urethra into the bladder, sometimes even beyond the bladder, up into the ureters, okay? Your urinary tract is sterile, okay, once it gets beyond the urethra. So urine is sterile until it comes out, and then it's not sterile anymore. The most common hospital-acquired infection is a UTI. When we talk about the bacteria that cause it, the most common bacteria causing it is E. coli. Risk factors have to do with, not emptying the bladder completely. So urinary retention is a big risk factor for UTIs. Contamination of the perineal or urethral area. What does that mean? I think I talked about this a little bit. So for people that wear briefs, people that are incontinent, it's very, very important to make sure that they are changed regularly, that they're kept clean. If any stool or feces, especially stool, that's sitting there at the perineal area for any period of time, E. coli is normally found in the GI tract. It's kept in check there, and it's not, destructive or problematic when it's in the GI tract. It is problematic when it gets into the urinary tract. So making sure that patients are kept clean and dry is critically important. When we talk about older women, E. coli, very, very common, and that all comes from not wiping properly. For women, it's important that they have to wipe from front to back. Arthritis, confusion, lots of different factors can affect the ability of older ladies to be able to wipe properly, and that's another risk factor. Wiping from back to front, you're just drawing the E. coli from any stool from the rectum right to the urinary meatus and up the urethra into the urinary tract. Female anatomy in general makes for a higher incidence, so women more than men tend to have urinary tract infections. It just has to do with the proximity of the rectum and anus to the urinary meatus. Men, not so much. They've got a penis that's kind of diverting away from the rectum and anus. So make sure that you understand all these risk factors. What are the signs and symptoms of a urinary tract infection? I think we all know them. Urinary urgency, I have to go now. Frequency, going constantly, but kind of only like dribble. Burning sensation, if the urine smells foul smelling, or if it's cloudy. If we see blood in the urine, that's hematuria. Sometimes even pelvic pain. For older adults, that can actually progress into changes in cognition. So fatigue, confusion, delirium even. Very important to make sure that signs and symptoms of cystitis or UTIs are identified quickly in older folks to prevent the onset of those kinds of cognitive complications that can happen. The word cystitis means bladder infection. And that's important for you to know. It's very, very common. Pelvic pain, pelvic pressure. And then there's pyelonephritis, which is an infection in the kidneys. That can actually be far more painful, can go systemic, so leading to costovertebral tenderness. So in other words, the costovertebral angle is the flank area. It's right around here, vertebrae. So right in here, the flank area, which is the location of the kidneys. Patient can present with fever, chills, even nausea and vomiting. And that's very important to be treated right away, because if it's not treated, a kidney infection that's standing for a period of time can lead to kidney damage, which can lead to kidney failure, and you need your kidneys. The next slide talks about cystitis, inflammation because of an infection in the bladder wall, and then pyelonephritis, like I said, which is an infection that's actually in the kidneys themselves. One of the other complications that can happen with UTIs, something called urosepsis. Sepsis, which is a generalized systemic infection, can be caused by a urinary tract infection that's either untreated or not treated appropriately. It's very serious. It can lead to septicemia, septic shock, and even death in older folks. So, predisposing factors: catheter, 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 catheter. Any kind of urinary catheter, indwelling, is an even higher risk because you've got just an open route through the urethra into the bladder 24 hours a day, 7 days a week. Any recent urinary tract infections, any recent instrumentation. What does that mean? Any diagnostic tests, like maybe a cystoscopy, which is a scope that goes through the urethra into the bladder. It's invasive and it can introduce bacteria into the bladder, causing cystitis. That's all important to know. Voiding patterns are important as a predisposing factor. Well, what does that mean? Holding your urine for any lengthy period of time, not a good idea, especially for women. The longer that the urine sits in the urinary bladder, which is just a holding tank, a storage facility for urine, the higher the risk is of having a urinary tract infection. And then we talked about the signs and symptoms, which is the urgency, the frequency, burning pain, the urine looks cloudy, or it looks like it's got things floating in it, sediment, hematuria, blood in the urine, or the urine kind of looks the color of my Snapple, which is never good, right? All these things are signs and symptoms of urinary tract infection, cystitis. We will order a urinary analysis, urine analysis, and then sometimes culture and sensitivity. The culture, again, will determine what kind of bacteria have caused the infection. The sensitivity will tell us what antibiotics particularly are those bacteria susceptible to. So what do we need to use to treat the patient? These are all things that you need to know. You have a slide with nursing diagnoses that are appropriate for UTIs. Then let's talk about what is your job as the nurse in caring for a patient with UTIs. Well, number one, administer antimicrobials, antibiotics, because it's usually bacteria causing the infection. The most commonly used antibiotic for UTIs is trimethoprim sulfamethoxazole. That's a combination drug. It is a sulfa-based drug. Trade names are Bactrim or Septra, very commonly used. And for people that have kind of recurrent UTIs or hard to treat, ciprofloxacin, Cipro, is one of the most common drugs that's ordered. Make sure you know those two antibiotics, trimethoprim sulfamethoxazole and ciprofloxacin. And in case you don't recall, ciprofloxacin, number one adverse effect potential, Achilles tendon rupture, tendinitis. Don't forget it. The next thing is to provide pain control, pain relief. The slide talks about heat. Be careful when using heat. And remember, in a facility, and even if you're the nurse providing care at home, heat, use of a heating pad, requires a physician's order. Okay, that's not an independent nursing action. And then the other thing, urinary analgesics. Important drug, phenazopyridine. And that is a drug, doesn't treat the UTI, treats the pain. associated with the UTI. And that's one of those drugs that will turn the urine an orangey reddish color. So you want to make sure that you instruct your patient beforehand so that they're not surprised and thinking that they're, bleeding from the urethra. Of course, you would monitor their signs and symptoms and intake and output typically. Make sure that they are well hydrated. Unless it's contraindicated for some reason, average healthy adult should be taking in about 2,500 milliliters of fluid in a day. And that doesn't count any fluids that contain caffeine, right? So that would, no coffee, no tea, no sodas that have caffeine like Pepsi or Coke, right? Make sure that all the antibiotics are taken as directed. One of the most common reasons for multi-drug resistant organisms is the overuse or misuse, if you will, of antibiotics. People will take them for a couple of days, say, oh, I'm feeling better, everything's great, stop taking them, and then what they've done is they've contributed to that multi-drug resistant organism because the bacteria have been exposed to the antibiotic, but just a little bit. Not enough to kill them, but enough for them to recognize that antibiotic and kind of mutate and be resistant to that antibiotic sometime down the road. And then, make sure that we're teaching prevention. When it comes to medicine in general, prevention, it's so much easier to prevent something from happening than it is to treat it after it's already occurred. That's a big mistake that we make in this country. We don't talk enough to patients about diet and exercise and hydration and all the things that are important for good health. So make sure that you understand all of those factors. Next, we're going to talk about urological obstructions. So an obstruction, the word obstruction means a blockage. Usually when we're talking about a urological obstruction, it's in reference to something blocking the ureters, either one of them, unilateral, or both of them, bilateral. It can be partial, so some urine's getting through, or it can be complete, it's blocked. The onset can come on rapidly or slowly, but big problem, because if the ureter becomes obstructed and there's a backflow, so the urine just can't go any further. Remember, the renal pelvis, which is the bottom part of the kidney that actually becomes the ureter, can only hold about 15 milliliters of liquid, which is minuscule, but the kidneys are always filtering blood and always making urine. And so if it's blocked at the ureter, that kidney's only holding 15, maybe 30 milliliters tops. And what's going to happen is the kidney is going to start to become distended, and that can cause something called hydronephrosis. That can lead to permanent kidney damage. Very, very bad, okay? There are also things called urethral strictures. So the urethra, which is from the urinary bladder, the route outside by which urine flows, a stricture is a narrowing or tightening of. It can happen because of scar tissue. Some of the common causes are sexually transmitted infections that are untreated can actually cause that. And then, persistent trauma. Say somebody's got, been catheterized multiple times. Surgical instruments, they've had multiple, say, cystoscopies. And cancer can cause that. And also for men, enlarged prostate, BPH, benign prostatic hyperplasia, is one of the bigger causes. For urethral strictures, there's a higher incidence in men than in women. So women get the UTIs, men get the urethral strictures. Signs and symptoms. Well, they try to urinate, and it's difficult either starting the stream or maintaining the stream. They get dribble, or drip. They have to go to the bathroom constantly because when they do, it's only a little tiny bit of urine. They're never really fully emptying their bladder. And the treatment for that, well, depending on how bad it is, maybe we have to catheterize them because we cannot leave the bladder over full. We can do dilatation or dilation of the urethra, which is basically kind of a stretching of the urethral lumen to kind of widen it so that it eases the flow of urine. And then there are other things like a uroplasty, which are kind of extreme surgical procedures. I'm not going to get into those, but just make sure you understand that concept. The next thing we need to talk about Renal calculi. Renal calculi, kidney stones. Small stones, they're hard, just like stones, and they form in the urinary tract. They can form in the kidney. They can actually form in the bladder as well. So nephrolithiasis is the term for kidney stones, stones in the kidney. Ureterolithiasis is the term for stones in the ureter. Okay, calculi is actually the other term for stones. Okay, so renal calculi, kidney stones. There's a nice picture slide that shows you the different areas where stones can form. There are lots of reasons why people get kidney stones, and I will tell you this. When you talk about pain, kidney stones are probably in the top 5 most painful conditions that a person can have. I've never had one. My husband's had a couple. I've had multiple patients over the years come into the ER that have had them. And I can tell you that typically it is a 10 or a 12 out of 10 or a 15 out of 10 as far as agonizing pain is concerned, especially when they start to move, because this is the problem. If a stone forms within the kidney, well, and the kidney's making urine, so as the urine flows, it's kind of dragging the stone with it. And so just imagine this little hard particle that's kind of trying to get through the teeny microscopic tubules within the kidney and the ureter every step of the way. Very painful. And it's important to note that it's colicky pain. In other words, the pain is intermittent. Doesn't just stay. Every time there's a little flow of urine, it hurts, ooh, and then it stops. And then more flow of urine, ooh, and then it stops. So it comes and it goes. Okay, that's important to remember. So colicky, intermittent pain. And where is the pain? We'll talk about that in a minute, but it's funny because the pain can be deferred or referred rather to other areas. When we talk about the pathophysiology, the urine is usually concentrated. So we're talking about the, how concentrated or dilute is urine. If the urine's very concentrated, the patient's not well hydrated, for example, then some of those toxins, urinary salts, we call them salts, but they're not necessarily salt. Matter of fact, the most common is calcium oxalate. Don't confuse that with calcium. So the patient with calcium oxalate kidney stones actually needs to increase their calcium intake, but they need to stay away from foods that contain calcium oxalate, which are things like dark chocolate. And we'll talk more about that in a minute. Stones are measured usually with a CT scan or an ultrasound. If a stone is less than about 5 millimeters, which is pretty tiny, but large in relationship to the inner workings of the kidney and the ureters, they can be passed on their own, but they are painful. Anything larger than that, it's going to require some type of treatment, and that's a problem. And depending on the size of the stone and the location of the stone will dictate what the treatment is. The next slide talks about the etiology of it, and so some people are just genetically predisposed to stones. Can't really say why. It's just one of those things. Chronic dehydration, because you've got highly concentrated urine, is another risk factor. Poor diet habits, so diets that are really, really high in salts and sugars and proteins, obesity, risk factor. And then infection. So chronic UTIs can be a predisposing factor for someone having kidney stones. And kidney stones are more common in men than they are in women. I don't know why. Signs and symptoms. So for nephrolithiasis, in other words, the stone is in the kidney, the costovertebral angle pain, and sometimes we'll even see frank blood in the urine, hematuria. If the stone has left the kidney and is now in the ureter, so now ureterolithiasis, that's a mouthful, they can have flank pain, side pain, they can even have lower abdominal pain. Pain will radiate even to the genitalia. For men, they will complain of pain at the tip of the penis even. It's very, very bad. Constantly this urge to void. I have to go, and then nothing's coming out. Frequency, dysuria, which is painful urination, hematuria, sometimes even to the point of nausea and vomiting. And the nausea and vomiting can be related also to the intense pain that they're having. If you've ever been in that kind of pain or know someone that's been in that kind of pain, severe and prolonged pain like that can cause nausea and vomiting. So that's no fun. Then the next slide talks about bladder stones. So yes, a stone can even form, or a calculus can form inside the bladder. And typically with that, not quite as painful because you've got a bigger space until it's trying to pass through the urethra, then it's painful. Signs and symptoms would be hematuria, frank blood in the urine, or oliguria. Oliguria means decreased urine output. Anuria, there's no urine output. And that can happen because if the stone gets lodged at the base of the bladder, where it enters the urethra, it's going to block the flow of urine, and that's a warning sign. Again, prevention, number one thing that you have to be concerned with. It's easier to prevent than it is to treat. Make sure patients are well hydrated. If a patient has a stone that's less than 5 millimeters and they are able to pass it, very important that you know this, so pay attention. What we will do is we will provide the patient, if it's a male, we'll give them a urinal. If it's a female, we will give them a hat. And remember, a hat is the little thing that goes in the toilet. So instead of actually peeing in the toilet, they're peeing into the hat. And then we will give them a strainer. Yep, a strainer. It kind of looks like a strainer that you use, say, for pasta, except it's teeny tiny, very fine. And we want them to strain their urine every time they pee. Why? Because we want to find the stone. Hopefully, they pass the stone. They're able to strain it, put it into a little sterile container. We'll send it to the lab. And at the lab, they can determine what the makeup of the stone is. That's important. Why is that important? Because then if we know what the stone's made from, we can kind of direct and educate the patient to avoid those things. And calcium oxalate is the number one reason. Uric acid, there are stones that are comprised of uric acid as well. And uric acid is the offender for people with a condition called gout. So, a high buildup of uric acid, but that's usually secondary to diet and other things. But people with gout can be more prone to kidney stones because of those high levels of uric acid. So, hydration, diet, telling them what they should and shouldn't eat. And then, of course, exercise is always important. Move. You got to move, right? When we talk about treatment, there are a couple things that you do need to know. Treatment for therapeutic interventions. If they're small stones, then usually we're talking about hydration. So if they come into the ER and we do an ultrasound and say, he's got a 3 millimeter stone, we're going to IV fluids, kind of push fluids to try to force the stone to move along and get out. Analgesics, of course, to manage the pain because the pain is significant. I can't say that enough. Sometimes they'll use a drug, it's an alpha blocker, it's called tamsulosin, which is also used for benign prostatic hyperplasia. And we'll talk about that more when we get into BPH. And then if it's a larger stone, they're going to be symptomatic, I promise. IV fluids, pain control, sometimes thiazide diuretics, lower dosages, again, to kind of kick the kidneys in overdrive, right, to kind of make the urine move. Allopurinol, and then the one you need to know for sure is lithotripsy. Extracorporeal shock wave lithotripsy. And so the next slide actually has a little picture. I'm going to do my best to try to describe to you what is happening. So the patient is brought into a room, they're placed on a table, and we're basically using shock waves through water I call it pulverize or sandblast a large stone. So the stone is larger than 5 millimeters. We know it's not going to be able to pass through the urinary tract. So what we do is we basically hit it with this shock wave, bam, and bust it up into a bunch of teeny tiny little particles. And those teeny tiny particles, then the patient will be able to pass without problems. Still painful, but at least they'll be able to pass. If lithotripsy is not indicated, well, some other things that can be done. Cystoscopy, scope into the bladder, like I talked about before. Uretolithotomy, we may have to go into the ureter. We may have to go in surgically and remove the stone. So, lots of different ways, but make sure you know extracorporeal shock wave lithotripsy. Say that 3 times fast.
Okay.
All right, so I'm going to stop lecturing right now at this point, and then I'm going to do a new video, and we're going to be starting off continuing this chapter 37. Ta-ta for now, guys.